Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. The drug of the day is going to be Pimavanserin. Brand name is Nuplazid. Before we get into it, reminder, go check out reallifepharmacology.com. We've got a list, 31-page PDF, absolutely free to you. Simply an email will get you access to that. Tons of great reminders, clinical practice pearls, as well as things that show up on board exams and pharmacology exams throughout your career too. So definitely a no-brainer. Go snag that at reallifepharmacology.com. All right, let's get into Pimavanserin, brand name Nuplazid. This is an antipsychotic. It would be considered an atypical antipsychotic. This medication is approved for the treatment of hallucinations and delusions associated with Parkinson's disease psychosis. Okay, that is its specific indication, and the likelihood you see it for something else is pretty unlikely at this point because it's actually very, very expensive. Now, it differs pretty significantly from traditional antipsychotics in that it really doesn't block dopamine receptors at all. So that makes it unique in Parkinson's disease because drugs that block dopamine can worsen Parkinson's symptoms, or at least they're highly sensitive to dopamine blockade. So if it doesn't work by dopamine blockade, how does it work? So Pimavanserin works primarily as a selective serotonin 5-HT2A inverse agonist and antagonist. It also has some minor activity at 5-HT2C receptors as well. So ultimately, this helps alleviate psychotic symptoms without messing up that dopamine pathway that needs to be preserved in Parkinson's disease to obviously help allow people to better function and move. Okay? So because of this dopamine-sparing effect, this is the primary reason that it doesn't worsen those motor symptoms in Parkinson's disease. So really, really important concept there with this medication and understanding why it tends to be a little bit better in Parkinson's disease. Another couple things I'll point out. I've covered clozapine and I've covered quetiapine. Those two agents have a lower dopamine blocking effect than many of the other antipsychotics. And you will most likely see quetiapine utilized first in psychosis in relation to Parkinson's disease. Okay, it's cheaper. Clinicians have more comfort level with it, and that's usually where you're going to see clinicians go first is trying Seroquel before they get to a medication like Pimavanserin. Sticking on Pimavanserin, I wanted to point out a couple of things. We don't really have much antihistamine or anticholinergic action in its mechanism of action as well. So that's a nice thing. Patients with Parkinson's disease, they tend to be a little bit older. They tend to be not that tolerant of anticholinergic medications. And so not having any anticholinergic activity or very minimal, that is a really key point with Pimavanserin and a potential benefit there. All right, let's talk dosing quick. Standard dose of Pimavanserin is 34 milligrams once daily. It can be given with or without food, so usually not too much of an issue there. And the starting dose of 34 is typically going to be the treatment dose. And so the titration, the changing of doses usually isn't too much of a big deal with this medication versus, quetiapine or risperidone or, any other antipsychotic. We've got a bunch of different dosages that we can go to, and we can titrate up and down and those sort of things. So can be advantageous in ways, but also can be easier for the clinician just to, prescribe that dose and make sure they tolerate it. I will say there is one exception to that for sure. And I'll get into a little bit more details in the drug interaction section. But in patients who are taking a CYP3A4 inhibitor, pimavanserin is broken down by this enzyme. So in those cases, if you've got a strong CYP3A4 inhibitor on board, that's a situation where we may reduce down to 10 milligrams daily. And those are the two dosage forms that this medication comes in, is 34 milligrams and 10 milligrams. All right, let's talk kinetics a little bit. Probably the most important thing associated with pimavanserin is the onset of action is generally pretty slow for most patients. So it's going to take up to, maybe a couple weeks for that onset and for benefit to start showing up. So that can definitely be a challenge in your patients. And it's definitely a great clinician education point that this medication is not meant for, PRN acute relief of, short-term hallucinations and psychosis. It's not meant for that. It's not designed for that. So that's definitely an important point as far as the kinetics go and as far as the onset of action goes. It does have generally a longer half-life, 57 hours, I believe it's what's reported in the literature on average. It does take a while to get to steady state, 10 to 12 days. And so, kind of that continuous dosing to get to that steady state is an important thing there. And then, of course, it being a CYP3A4 substrate is important as well, which I'll, talk about those drug interactions coming up here. Adverse effect profile with this medication. Pay attention to edema. There can be some GI upset, and sometimes, whenever you have drugs that work in and on the brain and around the brain, worsening CNS changes can happen. Confusion and worsening hallucinations have been reported with this medication. Another thing to think about is QT prolongation. So although it differs from kind of your standard dopamine antagonists, QTC prolongation is a significant clinical concern. Somnolence or sedation can occur, but generally I would say it's reported less common than a medication like quetiapine, for example. Fall risk, orthostasis, I would say the risk is there, but again, maybe not quite as severe as some of the other antipsychotics. All right, the boxed warning for antipsychotics does apply to pimavanserin. So that boxed warning for increased mortality in elderly patients with dementia-related psychosis, that is true of this medication as well as all the other antipsychotics. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or the NAPLEX exam, go check out meded101.com/store. We've got a growing list of resources there. If you're a nurse, healthcare professional of any other sort, med student, we've got case studies, we've got books on drug interactions, drug-food interactions, all sorts of unique resources that can help you learn pharmacology. So go check that out. All your purchases there go directly to help support this podcast. So again, meded101.com/store. All right, wrapping up with drug interactions. So CYP3A4, obviously it's a big enzyme, important enzyme in drug breakdown. Strong CYP3A4 inhibitors such as clarithromycin, ketoconazole, these medications can significantly increase pimavanserin concentrations and usually necessitate a dose reduction. Okay, so that's an important one to remember. On the flip side, if we've got CYP3A4 inducers, such as rifampin or carbamazepine. These reduce efficacy, and in general, I would say the combination of using a rifampin with a pimavanserin or carbamazepine with pimavanserin, those combinations generally are not recommended. You're going to end up giving them a medication that's likely ineffective or not going to get to adequate concentrations. And then the last drug interaction I wanted to mention was QTC prolongation. So any type of patient taking antiarrhythmics like amiodarone, fluoroquinolone antibiotics like levofloxacin, for example, or macrolide antibiotics. These are all notorious for causing QT prolongation. So understanding your patient's risk factors and identifying if they're on those other medications, may prompt further monitoring and, checking an EKG, for example, or reducing the dose or finding alternatives or whatever the case may be. So pay attention to that as far as drug interactions go as well. All right, so wrapping up here, a couple of quick clinical pearls. Remember that pimavanserin does not block dopamine receptors. Okay, so it's classified as an antipsychotic, but it does not block dopamine receptors. And because of this, it can avoid worsening Parkinson's motor symptoms. Okay, so that's really the primary benefit of this medication. Pay attention to those psychotic symptoms, and recall that this medication does take a little while to work. So maybe take up to a few weeks for maximum effect. So remember that. Definitely an important thing for sure. This medication is not meant for acute agitation, hallucinations, and psychotic behaviors. Okay, it's meant for a more chronic basis, and that onset is slow and gradual, like I mentioned. All right, well, that's going to wrap up the podcast for today. Do me a huge favor, leave a rating review on iTunes or wherever you're listening. Go check out that free PDF. Simply an email will get you access to that at reallifepharmacology.com. And of course, support the sponsor, meded101.com/store. If you have comments, suggestions, reach out to me, mededucation101@gmail.com. You can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thank you all so much for listening. Take care. Have a great rest of your day.